Assalamu alaikum. This is Ikra Kausar, roll number BP1650091 from 4th Professional Morning. My group number is 20 and the topic of my presentation is atrial fibrillation. Before going to know what is atrial fibrillation, let's talk a little about the normal functioning of the heart. A healthy heart works continuously to pump blood around the body, beating regularly under the controlled electrical impulses that originate from the sinoatrial node, the heart's natural pacemaker. These impulses radiate from the top to the bottom of the heart in a coordinated way. Each heartbeat consists of two stages where blood enters the atria which subsequently contract and forces blood into the ventricles. These in turn also contract, forcing blood out of the heart into the pulmonary and systemic circulation. Now, what is atrial fibrillation? Atrial fibrillation is an irregular and sometimes very fast heartbeat. What happens in atrial fibrillation? Basically, electric impulses do not originate in the sinoatrial node. As you can see here in the diagram, the electric impulses are not originated from the sinoatrial node as in the normal heart. These abnormal electrical signals are actually become rapid and disorganized, radiated through the atrial walls in an uncoordinated manner. This can cause the walls of the atria to fibrillate or quiver rapidly rather than contracting normally. Atrial fibrillation can come or go or be constant. It is more common in people with heart conditions and in older people than in younger people. Atrial fibrillation can lead to three bad health outcomes. Firstly, the symptoms can make a person unable to do their normal activities. Over the long term, a very fast heartbeat can damage the heart muscle. Atrial fibrillation can cause stroke when blood clots form in the heart and travel to the brain. What happens here? That is, during atrial fibrillation, because the atria do not contract regularly, blood does not empty efficiently into the ventricles and begins to pool in the atria. As a result, this pooling of blood can cause clots to form, which if dislodged can travel into the bloodstream towards the brain and prevent the normal flow of blood. The reduced supply of blood and oxygen to a particular part of the brain can result in tissue death, leading to ischemic stroke. How would I know if I have atrial fibrillation? Many people have symptoms. They include palpitations, that is the pounding in the chest, tiredness, and mainly the shortness of breath. Your doctor may see atrial fibrillation by performing an electrocardiogram, that is ECG, if an episode occurs during the test. If you have symptoms that could be atrial fibrillation but your ECG is normal, then your doctor may send you for a test that records your heartbeat while you're doing your normal activities. If you have atrial fibrillation, your doctor may do an electrocardiogram to look for heart problems. Echocardiogram use sound waves to take picture of your heart. What is the treatment? Atrial fibrillation treatment goals include reducing the frequency and severity of symptoms, preventing the stroke, preventing the complications of thromboembolism and tachycardia related cardiomyopathy, that is tachycardia induced heart failure. The initial treatment objective is to control the ventricular rate by using the beta blockers or calcium channel blockers. and the aim is to achieve a resting state between 60 and 110 beats per minute. The next objective is a restoration and the maintenance of normal sinus rhythm, usually by DC cardioversion. A single large dose of propafenone or flecainide may be used, but safety is initially documented in a monitored setting. Intravenous ibutylide can also restore sinus rhythm promptly. Selection of patients for anticoagulation with aspirin or warfarin should be based on the CHADS2 score. Here is the case study. Patient D is a man, 68 years of age, who presents to the emergency department late one evening complaining of increasing shortness of breath, dizziness, and the sensation of his heart racing. On admission, his heart rate is 160 beats per minute, blood pressure 100 by 50 millimeters of mercury, respirations 26 breaths per minute, and oxygen saturation 88% on room air. Patient D says that his symptoms started abruptly earlier that day and have steadily become worse. He also reports a history of long-standing hypertension and coronary artery disease. Now let's discuss the SOAP notes. Here is the subjective. Chief complaint, shortness of breath. Characterization, shortness of breath, dizziness, sensation of heart racing. History of long-standing hypertension, coronary artery disease. Objective include gender male, age 68 years. An electrocardiogram ECG is performed that shows a narrow QRS, a complex tachycardia with an irregular rhythm. Vital findings are heart rate 160 beats per minute, blood pressure 100 by 50 millimeters of mercury, respiration 20 breaths per minute. Assessment. Assessment is made on his past medical history, on the basis of his symptoms, and also the diagnosis confirms on the electrocardiogram which is performed that shows a QRS complex narrow tachycardia, and the diagnosis confirms the atrial fibrillation with rapid ventricular response. Now here is the plan. So firstly, the goal of the treatment is to slow his heart rate. Therefore, a calcium channel blocker 20 mg of diltiazem is prescribed to be given by IV. Oxygen via nasal cannula at 2 liters is started. A diltiazem bolus may be repeated after 15 minutes if the desired rate control is not achieved from initial bolus. Additional laboratory and diagnostic tests are ordered to rule out, identify any precipitating causes for the arrhythmia. His laboratory data showing normal serum electrolyte, normal renal function studies, normal thyroid function test, and liver function test. His hematocrit and hemoglobin are within normal limits. His cardiac enzymes and troponin are negative for myocardial infarction. However, his chest X-ray shows some congestion in his lower lobes consistent with mild congestive heart failure. So, intravenous furosemide 40 mg is prescribed to relieve pulmonary congestion. After the patient stabilizes, that is his rate control, and then oral anticoagulation with warfarin will begin due to high risk of thromboembolic events. So here are some notes which needs to be considered during treating this patient, that is the blood pressure, ECG, and oxygen saturation. Monitoring should be done continuously, such as falling BP, decreasing oxygen saturation, and failure to control rate should be noted and handled immediately. If desired rate control is not achieved, then additional medications can be prescribed, such as procainamide, asmolol, metoprolol, and propranolol. These medications will also given if the patient show some side effects to the diltiazem, and also if he is not showing any side effect but the desired rate control is not achieved, then these medications can also be prescribed. Once the rate control is achieved and maintained, the patient's vital signs are stable and other signs, that is the signs of congestive heart failure, have resolved, the patient may be changed to an oral dose for maintenance therapy. For high-risk patients where warfarin is the drug of choice, in an inpatient setting, intravenous heparin may be used to provide adequate anticoagulation until warfarin reaches a therapeutic serum level. So, indications that medical therapy is effective in managing his atrial fibrillation will include his ability to perform normal activities without the symptoms of fatigue, dyspnea, dizziness, or palpitations. And vital signs are within the desired limits, and he is not showing any signs for the thromboembolic events. So that's all for this case. Thank you.